Department of Anesthesia and STU, Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. I want to welcome everyone on board, and I want to appreciate the President, Nigerian Society of Anesthetists, the NSA executives, and the Board of Trustees for all the privileges given to the resident to learn and improve on our academic and clinical performance. And also want to appreciate them for nominating me to be the moderator of these academic sessions holding this very evening. Okay, so this evening, Dr. Salahuddin Mbolale, a registrar from the Department of Anesthesia, General Hospital, Lagos, will be leading a discussion on a topic post-oximetry, principles and clinical application. While the presentation is ongoing, I encourage all the participants to please mute their device and also label any unknown device for easy identification. If you have any question, you can put down the question in the chat box, or after the presentation, you can raise your electronic hand so that you'll be called to ask your question or make contribution. So Dr. Salahuddin, who is a registrar from Department of Anesthesia, General Hospital, Lagos, you have 40 minutes to make your presentation. Thereafter, we can entertain question, contribution from the resident, and clarifications from our trainers. We welcome each and everyone, especially our trainers, to this important academic session. Dr. Salahuddin, you can begin sharing your screen so that without much waste of our time, we commence the program. Thank you, everyone.
Dr. Ba, I think I've started sharing.
Okay.
Is it showing?
Yeah, it's showing. Yeah, it's showing. Okay, so you can begin the session.
My humble greetings to the President, NSA, the ESCO, Board of Trustees, our teachers, consultants, my senior registrars, for this privilege today to discussing post-oximetry, principle and clinical application. As introduced, I'm Dr. Salahuddin Mbolale, Registrar, Department of Anesthesia, GH Lagos. I'll be following this outline. Introduction, but before the details in introduction, I'll just give brief definition of these terms. Pulse oximetry is an act of continuous measurement of SpO2, that is arterial oxygen saturation. Pulse oximeter is a device that measures the arterial oxygen saturation, and SpO2 is the peripheral arterial oxygen saturation. Normal range 94% to 100%. In our environment, when it's getting to 92%, it becomes of concern. It's not popularly used in the operating room. Standard of care for all patients who receive general anesthesia or regional anesthesia or local anesthesia, also called the fifth vital signs, as well as following the measurements of the blood pressure, the pulse rate, the temperature, or the end-tidal CO2. It's a non-invasive method of measuring hemoglobin oxygen saturation with light signals transmitted through the tissue. Until 1980s, it used to be a large, cumbersome, and expensive oximeter that were used to monitor the pulse oximetry, as we can see in the diagram. So the limitation is not just the cumbersome, it also cannot differentiate absorbance of arterial blood from venous spectrum. But with modern technical advances, light emitting diodes transducer used to make small, less expensive, and easy to use oximeter. Not just that, this one can differentiate light absorbance of pulsatile arterial components from static components. Hence, it is called pulse oximeter because the absorbance, the transmitted light, and the transducer actually take the analysis from our arterial pulse. They are available in standalone device and also incorporated into multi-parameter monitors. The pulse oximeter is a device that have the following parts: a probe body, a case housing the microprocessor, two light emitting diodes, emitting monochromic light at red, 60 nanometer wavelength, and infrared 940 nanometer wavelength. It has a probe body. It has a photo detector at the other end. It has a screen displaying the vitals of oxygen saturation, pulse rates, and plethysmographic waveform of the pulse. Some have extension wire. Many of them are battery, for the function with battery, and they have alarm limits can be set for very low or SpO2 or very high pulse rates. So how is it used? It's positioned on the finger, usually the fourth and fifth finger because of its vascularity. It can be placed on the toe, earlobe, or nose, where two light emitting diode is produce beam at red and infrared frequency, respectively, on one hand. Then the sensitive photodetector on the other side of it generates a voltage proportional to the transmitted light, where the transducer relays it into the microprocessor. This microprocessor gives the figure that we read as the vital sign and also give us continuous sounds as the pulse oximeter is in use. The operating principle of the pulse oximeter is based on spectrophotometry and plethysmography to non-invasively measure oxygen saturation in arterial blood, following Bell-Lambert's law. Bell's law says that the intensity of transmitted light decreases exponentially as the concentration of the substance increases. As the blood volume, the arterial volume increase, the pulse signal is raised, the absorption is high, especially in highly perfused patients. The little light that escape to the photodiode and are analyzed by the photodetector, which relates to the transducer microprocessor. They produce it as a ratio of figure that we read as the SpO2. In low concentration, the reverse happens, like less will be absorbed and more will escape to the photodiode, and the ratio will come out as low SpO2. While the Lambert's law says that the intensity of transmitted light decreases exponentially as the distance traveled through the substance increases. So the more volume, the path length, it's higher, the distance traveled is less, but the absorption volume is high, and by the time the ratio of the amount absorbed through the emitted light to the amount that escaped to the photodiode is relayed to the transducer, then the appropriate figure, relatively in high volume, highly perfused patients, it will be reported as high SpO2, and in low perfused patients, the ratio will be low. So one of the principles is spectrophotometry that is based on the Bell-Lambert's law, a combination of two laws describing absorption of monochromatic light by a transparent substance through which it passes. Transparent are tissues that allow emitted light, that allow light to pass through them. And when it's opaque, then that means light cannot be transmitted through them. So they're expressed with the equation of the intensity of light as the multiplication of the incidental light on that photodiode, multiplication with Bayes' natural logarithm of the distance traveled by the solutes, by the light, distance traveled by the emitted light, and the concentration of the solute raised to the extinction coefficient of the constant given at solute at specific wavelengths. So the oxyhemoglobin is absorbed more at the infrared light than at the red light, while the deoxyhemoglobin is absorbed more at the red light than the infrared light. So the pulse oximeter will estimate the SpO2 from the differentials of the absorption in the tissue to give us the results. So can also be said that it can directly or indirectly give us the arterial content of the oxygen. Directly in the sense that I mean normal individual. Indirectly, like in cases of chronic obstructive pulmonary disease, in case of restrictive lung disease or septic patients where the oxygen is available, the hemoglobin is able to absorb, to receive the oxygen, but it's not available to the tissue. So, but is related in the sense that calculating the oxygen content of the arterial blood, we will need the oxygen bound to the hemoglobin addition with the oxygen that dissolve in the plasma. And getting the oxygen bound to the hemoglobin, we have to multiply 1.3 constant figure with reduced hemoglobin value and also hemoglobin value, which is our SpO2, before we add it to the oxygen dissolved in the plasma to get the oxygen content or oxygen flux of the tissue. So the pulse oximetry is no direct information of oxygen delivery to the tissue. So this figure is just depicting that pressure pressure of oxygen less than 75, our SpO2 will not reliable to be used because we need maximum saturation, maximum pressure of that oxygen saturation to get our accurate SpO2 reading. And the blood oxygen level pulse oximeter chart interpretation goes like this. 95% to 100% is normal blood level or optimal or highly perfused patients. 91 to 95%, the blood level is of concern. And when it's getting less than 90%, the low blood oxygen level, it impedes low blood oxygen level. 80 to 85, that low oxygen saturation begins to affect the brain, the hypoxia. And hypoxia is a avoidable complications perioperatively or in ICU just to avoid mortality and morbidity. At 65%, cyanosis ensue. So the second principle, plethysmography, that is during each cardiac cycle, light absorption by light tissue varies cyclically. So this is like a picture of the cardiac output. During that slow absorption, it's caused by non-pulsatile arterial blood, venous blood, the bone, the pigments. We call that the static, the direct current component. And the plate might be this low, depicting low perfusion. During systole, a bulk of the cardiac output is pumped during systole. So the postal expansion of the arterial bed will produce an increase in the path length, thereby increasing the absorption. We call this alternating current because it keeps changing as cardiac output, systole coming, the pulse, the plate also changes in amplitude. So by the time we're having heights of this kind of amplitude, we say, okay, patient is perfused or normal signal. So the microprocessor will determine this alternating current, this pulsatile, continuously changing current of absorption of, at each wavelength and divides it by the corresponding static non-pulsatile components. Thus, we say the ratio of the red to infrared of these pulsatile differences can be used to compute the SpO2, which is an estimate of the arterial oxygen saturation. So this diagrammatic representation of what I explained earlier, the measure ratio is compared with the stored ones in the microprocessor of the device. And really there's some figure configured in each device that the ratio will be compared, and then relatively the results will be corresponding SpO2 will be displayed. The displayed SpO2 represents the mean of the measurements obtained during 3 to 6 seconds back, whereas the data keep updating every 0.5 to 1.0 second. What this means that once a pulse, let's say at A time, is picked up, it's been sent to the transducer, it's been processed, and as it's relaying back, B is picked up. So we see that the reading on the pulse oximeter keep changing, keep coming, fluctuating, reporting, analyzing, like that continuously. So that means the ratio is ratio of red to infrared, that is reduced hemoglobin to oxyhemoglobin at alternating pulsatile tissue of C60 and non-pulsatile at red to the pulsatile at infrared and non-pulsatile at infrared. So far, I've been discussing the molecular basis of the principles of pulse oximetry. So, and which is basis of the mechanism of its action. So in this slide is just summary of it all. The oxygen saturation is estimated by measuring the transmission of light through pulsatile vascular tissue bed. This is based on Bayes and Lambert's law. The amount of light transmitted depends on many factors. The light absorbed by non-pulsatile tissue, which is constant, and the non-constant absorption, which is the alternate component, is the result of the arterial pulsation. The ratio of the pulsatile transmitted red to infrared light is calculated and compared with stored calibration curves to give estimated SpO2. So the signal is displayed ideally as continuous tracing, showing quality of signal and numerical value of SpO2. So before I go into the application, I just want to talk about types of pulse oximeter. We have two types: transmission pulse oximetry and reflectant pulse oximetry. The transmission pulse oximetry uses light beam transmitted through a vascular bed and is detected on the opposite side of the bed. The light emitting diode and the photodiode are on the opposite side. This is the commonly used one that we have. But for reflectant, the light emitting diode and the photodiode, they are on the same side. The light emitted is backscattered, but the advantage of it is that it can signal low perfusion better because it doesn't have to penetrate. Because in low perfusion, if it has to penetrate, then it's going to bring out the corresponding low SpO2. So the limitation here is that that's weaker signals, and the probe design must eliminate light that pass directly through it. And vasoconstriction can overestimate, because in vasoconstriction, there's going to be venous congestion, and that venous congestion is going to appear like a full volume pulse, and then to just pick it and scatter and give us a pulse eye figure. So the existing coefficient I measure in the calculation of the transmitted intensity of the light transmitted. This is a measure of tendency of a substance to absorb light. And one of the limitations of pulse oximetry is that if you analyze all the variants of the oxygen saturation presence, the oxyhemoglobin, the reduced hemoglobin, the methemoglobin, the carboxyhemoglobin, it will not give us the fractional hemoglobin saturation. That is the ratio of the oxyhemoglobin to total hemoglobin species present in that tissue bed, in that medium. Whereas the ABG give us functional hemoglobin saturation. This one will just analyze differential absorption between oxyhemoglobin and reduced hemoglobin. So, like, this is a saturation coefficient for pulse oximetry, where the methemoglobin and even the oxyhemoglobin are being picked up at red wavelength and also at the infrared wavelength. So when we have this figure, we can't differentiate whether it's coming from the methemoglobin or it's coming from the carboxyhemoglobin, or how much hypoxic, how much poison patient has. But it's telling us this patient is getting this percentage of oxygen. So different sites of probe placement can be on the fingers, on the earlobe, on the nose, on the head, toes, on the tongue, cheek, on the penis. But they have their limitations. On the finger, which is the most. Hello, am I still on?
Yes.
Yes, we are
Hello, Dr.
listening.
Ba. Okay,
Go
oh,
ahead.
thank
You are
you.
audible.
Which is the most, thank you. Which is the most common and convenient and relatively accurate side and at rest, but the whole core body will be shaped periphery. But motion artifact is having nail polish or synthetic nail or fungal infection or comycosis, then the light emitted will not be able to penetrate very well and we won't get accurate picture. And doing resaturation and desaturation, detection is slower because the cardiac output is distributed to the core body parts first before getting to the periphery. So poor function on the same lip as the BP curve and IV line. In BP curve, there's going to be constriction, venous engorgement. So at that time, we might not get ready at that seconds. And for IV line, that line might be like block. And the medium, the blood, we want to find a contralateral part to perfuse the extremes of the finger. And usually the contralateral parts, they are usually smaller and they cannot take a relative volume from the body. So we might get poor function at that time. So the tool is also reliable, also giving us a reliable signal, especially in epidural block, where the vasodilatation effect comes and there is compensatory vasoconstriction that gets to the upper limb first. So if we have pulse oximeter at the upper limbs and at the toes during epidural block, we'll see that the one on the finger might be giving us pulse I first before the distribution gets to the one of the toes. Yeah, this is the same principle that cardiac output gets to the vital core organ, central part of the body before the periphery or the toes. So then for the nose, this nose responds rapidly to changes in saturation when the pulse oximeter is placed on the nose, because the nose is part of the central part of the body and is recommended in hypothermia and hypotension. Then treadmill levels position can give false low due to venous encouragement. So we have more of venous blood getting pulled up into the pulled down to the face, to the head, into the levels position. And the venous blood, we have more of reduced hemoglobin. So the ratio of that reduced hemoglobin will be like the one that will overshadow the arterial one. So it will give us a false low SpO2. Then for the ear, the central parts of the body, so it can give us a faster response. It will be better to use in hypothermia and hypertension, relative immune to vasoconstriction because the ear doesn't vasoconstrict, or you can get reading in reverse position due to the same reason as in the nose. The esophageal site that uses reflectant oximetry. So I will put it the way we put our Doppler, then just put the lights there to pick it. It's useful in bones, bones. is a core organ. It can give us a more consistent hemodynamic stability. The change.
Sorry, I cannot see the presenter. Or is it from my network?
No, it's not from your network. It's
No, the problem is global.
Yes, I learned that there is network problem all over. So let's wait for her. I will contact her privately. Even here in Bauchi, not only Lagos, it's raining heavily. So I can see a post too saying it's raining heavily in Lagos. So it's a terrible network.
Sorry,
At
how
least.
have I been locked out?
Okay, you're welcome. You're welcome.
Sorry, how long have I been locked out?
Just of recent, not long ago. You can begin sharing my screen. Okay.
I apologize. So after discussing the uses, the sites, then I come to the application. So it's commonly used in monitoring oxygenation for adults and their children in critical areas, in anesthesia, operating theater, during general anesthesia, during monitored anesthesia care or conscious sedation. Also, continue for continuous oxygen monitoring and the emergency room. Hello.
Go on.
Hello, Dr. Barr.
We can hear you. Go on. Go on.
Oh, thank you. Yes, monitoring oxygenation in neonatal area like neonatal intensive care unit, newborn nursery and delivery, and also in transportation of patient intra-hospital, maybe from ER to the theater or theater to ICU or to the ward, or inter-hospital on our center used for oxygenation, controlling of oxygen administration, titrate our FiO2 so we don't go to the toxic level of oxygenation. Also, and all. So they have to attach the pulse oximeter to check that, oh, the anastomosis, the vessel is still perfused. Then to determine systolic pressure, just as we do in palpation method, we feel the curve, we see the plate, take it as the systole, but it cannot give us the diastole. And the intrapartum fetal monitoring. So the limitation to its clinical application is that of this hemoglobinemia that I said that it has to absorb all the wavelengths in the medium, carboxy hemoglobin, methemoglobin is also absorbed by the pulse oximeter wavelength, leading to error estimating which one is the reduced hemoglobin or the oxy hemoglobin. So when we have this, we can supplement with multi-wavelength pole oximetry. This one will just give us all the wavelength figures separately. Then I'll talk more about that later. Extraneous energy source, because the problem with bright fluorescent or ambient light causes porous reading on the pulse oximeter, like interfering with the lights getting to the emitter, getting to the photodiode that will now be transduced, and this can be reduced by putting the sensor away from the ambient light. Then the transmission, the absorbed light will be reduced and the remaining of the transmitted light will just escape out. Then in nail polish and covering and difficulty detecting high oxygen partial pressure. Because when the oxygen manometer method, SpO2 will just be giving us 100%, even when the patient is getting to toxic. level. So then erratic figure in COPD because of the in sepsis, organism refuse the hemoglobin to release oxygen to the tissues. And we have some postal vein, especially in that is not especially that is in atrioventricular fistula, because there is a mixed venous blood at that fistula. So the arterial pulsation is coming, the one from the mixed blood is also coming. Then, and it does not indicate patient's ability to eliminate EtCO2. That one is the time of 3 to 6 seconds. So the partial pressure of oxygen falling greatly before the oxygen saturation starts to display to us. So it has electrical interference as well from electrosurgical units, that is on the diatemy, and is increased in patients with weak signal, pulse signal. Like especially when you are using a monopolar, where the light goes through the patient, and patient is hypovolemic, patient is having low signal. So signal of that diatemy might just take over this the little one that the body, the light will have absorbed on the medium, and the pulse is transient and limited to the duration of the rotation. Using that then at other time the pulse oximeter will now want to go back to its own natural medium. Then later they will use that again. There will be interference. So the interference keep coming and going, and you keep changing from one finger to the other. Very good. Let me check. Hello, am I still on?
Yes, you are.
Hello, Dr. Bauer.
Yeah.
Oh, thank you. Thank you. So to improve this signal, maybe there is hypothermia or there is electrical interference. You can do warming of the cooling extremities. You can try alternate sides or the placements. You can place a glove filled with warm water over the patient and can do digital nerve block. This one will give us that vessel congestion. Then they can do application of vasodilating cream. As we know, one of the properties of local anesthetics is vasodilatation. And the vasodilatation will improve heat loss, and they will be able to get our reading. So the alternative multi-parameter that I mentioned earlier, the bench for oximetry, calculates the actual concentration of the D-oxyhemoglobin, the one for the carboxyhemoglobin, methemoglobin, and then it will just give us and put the figure of the oxyhemoglobin here at the pulse rates. So it will analyze each of the wavelengths in that arterial medium. Hence, it calculates the actual oxygen. So we can say it's like a gold standard and classical method by which pulse oximeter is now calibrated to what we are using now, but it's not like in totality as the whole oximetry. But it's more bulky, it's expensive, and it requires constant maintenance. Some of them does not have this attached. If you don't use this attached probe, then you might need to take samples and then put in the cartridge to read it. So it can be invasive and it can be non-invasive, unlike pulse oximetry. So in conclusion, pulse oximetry is simple, convenient, inexpensive tools, which has unique advantage of continuous, non-invasive method of measuring hemoglobin saturation. It is a vital monitor for early detection of hypoxia in perioperative setting, because hypoxemia can be dangerous, increase morbidity and mortality, and the human eye might be poor detector of cyanosis. So lack of detection of hypoventilation and hypoxia, like I said, toxic level of the oxygen, how its two important limitations amongst other limitations. So there are novel pulse oximeters now that have been developed that can measure the pulse variability index, something and yes. So it's not because it's not really my topic, so I didn't go too much about it, but just since it's close to my conclusion, it's just an index for continuous non-invasive dynamic indication of fluid responsiveness in mechanically ventilated patients. So, like pulse oximeter uses the cardiac circle. This uses the respiratory circle. These are my references.
Thank you. Thank you. Thank
Thank
you
you
very
for
much.
listening.
Thank you very much, Dr. Saladin Bon, who is a registrar from General Hospital. Before we go ahead, permit me to introduce some of our trainers that joined during the session. One of them is the NSA president, who is Professor Olubobusola Briggs Alagbe. Then also the NSA president-elect, Professor Alhassan Muhammad Det, and one of our trainers, who is the board member of the WFS, Professor Elizabeth Mwamfu. Sir, Ma, you are all welcome. We really appreciate your presence. Then I don't think, let me check the chat box. We have all listened to the presentation. She began by describing some of the terminologies that we came across, and she also described the working principle of the pulse oximetry, which she talked about the spectral photometry, plethysmography, and she also talked on the Beer-Lambert's. She described the mechanism of actions of the pulse oximetry. She also did mention the different types of pulse oximetry, advantages and disadvantages of each, which include the transmission pulse oximetry and the reflectant pulse oximetry. She told us the different sites where we can actually obtain the reading of the pulse oximetry, advantages and disadvantages of it. She also highlighted some of the limitations in clinical practice of using pulse oximetry. And thereafter, she concluded and gave us her references. So from the chat box, I cannot see any question from the chat box. If there is someone who want to ask a question, make contribution from the resident, you can please indicate by raising of your electronic hand so that you will be called upon to talk. Thank you. Okay, Hassan Tijani, you can go ahead. You unmute and talk, please. Hassan Tijani.
All right, sir. Thank you very much for your presentation. Please, I will want the presenter to come about the factors that affect pulse oximeter readings, and then the factors that do not affect pulse oximeter readings. And then I also want to know if we can actually rely on the pulse oximeter reading in a neonate, in an infant that is below 6 months with a hemoglobin F, since we know that the readings of pulse oximeter was actually obtained using that of adult as a study. So can we rely on that? And then in my environment, we use this pigment we call lele in Hausa. So does it really affect the pulse oximeter reading as well? I want to know. Thank you very much.
Okay, thank you.
Hello?
Thank you.
Yes, we had it.
Hello, I can hear. So the lily, the last one you mentioned is not it doesn't form coats on the nail, and the pigment is not thick like that. It's just a stain on the nail. So I think we can rely on that. Then for the neon, so they have this companies, like I said. But the advantage is that it will be reflected over the neonate cell scalp. So it's not on the neonate cell periphery. So that's the little I can say. Then limitations that you said and advantage, like just like advantages and disadvantages, and differentiate the different wavelengths in the absorbance that it's analyzed, and the transmitted light can be the signals can have interference, maybe electrically or by the ambient light, alter its reading. Then some conditions like septic patients with obstructive or restrictive lung disease. So then they are hypoxic and some are hypercapnic. So in the figure, we might not rely except we now, because you just give us a fraction of their saturation. But to get the functional saturation, we have to use J in that instance. But the advantage of pulse oximeter is, one, it's not invasive, it's expensive, it is practically operable. If somebody that can understand the figure, and you tell the person this figure to this figure is normal, this figure to this figure is low, you can leave it for that for the person's hand. So it's easy to use, to understand, and many of them use battery. So you don't have to say network is affecting or electricity is affecting. Though it can only give the let's say show us the gas of life, but it can't tell us if the tissue are metabolizing. Like end-tidal CO2 that will tell us, okay, tissue are metabolizing, so this is the CO2. I think this is little I can respond. I have plenty teachers around that can add to it. Thank you.
Okay, well done. I can see another question from the chat box from Dr. Ndoka. What is the effect of methemoglobin and carbon monoxide on post-oximetry reading?
Carbon monoxide will give a false eye because it is picked at the red, it is not picked at the infrared. So it's not being analyzed, it's not having to be ratioed with another figure. So carboxy will give us a false eye. Methemoglobin will give us a false low because it will be ratio with the oxyhemoglobin because it is picked at the wavelength of 660 nanometer, also picked at the infrared wavelength, similar as the oxyhemoglobin.
Okay, well done. Another question from the chat box is, well done, man. Thanks for the presentation. What is is post-oximetry efficient at a low SpO2 reading of 50%?
No, from 75 is not, because the saturation pressure is not optimal for it to give an adequate. It's not reliable from 75 before you even get to 50. Thank you.
Okay, another question, I think, which was just addressed. If you had to choose between pulse oximeter and capnography, which will you choose and why? I think you have addressed this question. Then thanks for your presentation. What is the significance of PI, that's pulse index IT, that is seen on the pulse oximeter?
Okay.
Please let her answer. Please, hello, let her answer that one you said you think he has answered before, because some other people joined this webinar after she talked about it. Thank you.
Okay. You can answer the question on if you are to choose between the pulse oximeter and capnography, which will you choose and why?
Let me say okay. If I want to choose pulse oximetry on the account that it is readily available, it is cheap, it is compact, it can be used outside the operating room, like I've said, in diagnostic center, in the lab, on the ward, ambulance, in air. So one, then two, it's battery operated, unlike end-tidal CO2. I've not seen end-tidal capnogram that is using battery. In local setting as well, it's practically operatable. Even unlettered person can use it, and the calibration is easy to understand. Just say, okay, this percentage to this percentage. Unlike end-tidal CO2 that needs technical know-how. Person might be saying 35, be saying 65, don't know the difference. So you tell them that you know that okay, this pressure to this pressure, or this KPA to kilo Pascal, that's normal, then this is the abnormal. So then that is for pulse oximeter. But if I think of it that polarizing or not, it cannot tell me the viability of evidence of life. Because viability of evidence of life is that okay, taking oxygen, I'm able to metabolize it out to CO2. But pulse oximeter will just tell me that okay, I have gas in me. So ideally, I would, if I can have it, so it's for I don't know. I don't know how to answer this argument. I would say ETCO2 is is better. Then for the pulse index, I say the pulse index also give a continuous non-invasive responsiveness to ventilated patient absorbent that is picking. It's also picking the respiratory cycle as well. So is there a third one, sir? Dr. Barra?
Okay, I'm checking. Thank you for your presentation. Another question from P. So why is pulse oximeter incorrect in measuring abnormal hemoglobin?
Because it's fraction of the other abnormal hemoglobin, other species of hemoglobin in the arterial blood. So it's a fraction we are getting actually. And this fraction is also relative to the calibrated figure in the machine.
Okay, so
but if we
another
have a
question
co-oximetry that we analyze that this is
Hello?
So if you have a co-oximetry that we analyze for each variance of hemoglobin data.
Okay, so another question from the chat box.
Hello, am I still on?
Yes, which is the last question from the chat box. It's from Ryan Yusuf. He said, thank you for the presentation. You want to know what is isobestic point?
Okay, isobestic point determines the hemoglobin concentration regardless of the saturation. How does it do this? The infrared, the midpoint of the red to the infrared. The red is analyzing the reduced hemoglobin. The infrared is analyzing the Aussie hemoglobin. And at the midpoint is the isobestic point that is giving us that irrespective whether it's reduced or is full, there is hemoglobin saturation in this medium. That's it verifies the accuracy of the wavelength at a particular photometry wavelength. So when we have isobatic point reading, it means that there is the hemoglobin there is having it's having all its receptor. You know, we have 4 points on the oxygen bounded.
Okay. Thank you. This is the last question in the chat box. So I cannot see any hand being raised electronically. If there is any contribution from the resident or questions, you can raise hand before we hand over to our trainers. Okay. Thank you, Dr. Salahuddin Bola, for the nice presentation. At this point, I would like to hand over the moderation and the presentation to our trainers for clarification and trainers' input. Thank you for the presentation. Thank you, everyone. Okay, I can see Alassane is still online. So, and then the NSA president too, Professor Boswell, is also online.
You are all doing well. Thank you very much. But let me ask this before I come and give my closing remarks.
Okay.
What did I hear her talk about the use of pulse oximeter in the burn patient and its place in the burn patient? Did I hear you talk about that? Okay, so please respond to that.
No, if it's when I talk about that, it can also be placed in the esophagus, where we place it like in the Doppler, like it will now use the reflected pulse oximetry to give us the reading. The advantage is that in bones patients, especially the bones periphery, at least that was a reading.
Okay.
Hello, can you hear me?
Yes, yes.
Okay. Has she finished talking?
Dr. Salahuddin, are you done with
Is she
responding
still
to
with us?
Yes, ma. Now I can hear you.
Yeah, okay.
Now, ma.
Okay, Dr. Salahuddin, are you still talking?
Yes, ma. Yes, ma. Yes, ma. Yes.
Okay, go on.
Dr. Baraka, can you hear me?
Okay.
Ma. No. I just use it to emphasize the advantage of emphasize the advantage of the probe placed in the esophagus, especially in bones patients.
Yes, I agree. There's one more thing I want you to tell me. You have actually mentioned it, but I want you to have a practical, critical reasoning from one of the things you have mentioned and relate it in the burn patient. You have actually done well, Dr. Salahuddin, so don't be stopped. I just want you to. Yeah, you're coming close.
One patient tends to have carbon monoxide. They tend to have carbon monoxide poisoning. So they have the carboxy hemoglobin wavelength, interwavelength in the medium that the light emitted diode of the pulse oximeter wants to transmit and then relay and interpret to us.
So it can give us false readings. In which categories of burn patients now?
Carbon dioxide also have.
Which category of burn patients now?
Burns involving the head and neck.
What do you call that complex? What do you call them? What you call them? What inhalational burns, right? Are you with me, Dr. Salaudin? Do you understand how I'm taking you through this critical reasoning? Okay. You have actually done what Dr. Salaudin. So please, over to you, Dr. Sonny. I just want to bring it out in that manner that you must also wrap up your thoughts holistically,
yes,
right?
Thank you. Yes, thank you very much for this input. So in this case, once you have inhalational injury, we should not be carried away by the SpO2 reading showing 9900. Patient may be in hypoxemic setting clinically because, as rightly said by our chief, the patient post-oximetry reading may be showing you normal because of the inhalational injury of carboxyhemoglobin that she rightly said. So you can still go ahead and administer oxygen to the particular patient. So any other thing? Oh, it's already 1 minute to 6. So can we now end the discussion?
Excuse me, sir.
Yes, you can go ahead.
Sir, I came across pharyngeal pulse oximeter. So I don't know if that can be used in a burn patient, in which they attach the probe to an oropharyngeal airway and then put it in the mouth.
Okay, so Dr. Flau, can you press?
Yes, similar to, that's why I said just the way you want to put your Doppler, the way you put, when this instance now you're saying they go through the ETT, yes, just to get it. It's not that it will be placed there. It can't do transmissional pulse oximetry. So it's reflectance, it will reflect and backscatter. So you get your reading. If you take it out of the ETT so that you can continue the main reason why you put the ETT there, which is for oxygenation and ventilation.
Thank you very much. I want to appreciate all of you, the presenter and the moderator.
Sorry, sir. There is one of our consultants raising hand.
Okay.
Dr. Abdulhamid Jadel, sir, you can unmute and talk.
Thank you very much for the wonderful presentation. It is quite helpful. I just want to make some small information as regarding the inhalational burns. Inhalational burns could present with carbon monoxide or carboxyhemoglobin, just like earlier discussed. But carbon monoxide toxicity is common in burns that occurred in enclosure, irrespective of whether there is head and neck burns. So if there are anywhere burns happen that and there is an enclosure, maybe in a closed room or a closed kitchen, or patient took time before it came out of where burns has occurred. So inhalational injury is more likely to have occurred. And nowadays, there is this pulse oximeter by Mosimo, which has the capacity of even giving you the percentage of carbon monoxide hemoglobin within the system, in addition to the hemoglobin and the saturation all in one. Though it's a little bit more expensive, not much hospitals are rich or interested in having it. But if you're fortunate enough to have it within your system, it will give you a guide in those patients that have carbon monoxide toxicity, and that will determine the therapy you give. The moderator outlined that the patient could benefit from oxygen for like 4 to 6 hours if the carbon monoxide toxicity is a little bit high. That will lower the rate at which it gets flushed out of the system in such particular individuals. These are the small I wish to like highlight in the presentation. I hope I was audible enough and the information I wish to deliver was delivered appropriately.
Yes,
Yes,
sir.
sir.
Thank you very, very
Thank
much,
you very
sir.
much. Okay, so our trainee representative, in person of Dr. Shuaib, sir, you can continue.
Thank you very much. We want to appreciate the presenter and the moderator for taking us through today's our final section for the resident webinar series. And on behalf of the president, the ESCO and board of trustee, I want to appreciate our senior colleagues, trainer and teacher here present. And we also use this opportunity to wish our colleagues preparing for part 1 and part 2 DA and primary. We wish all of you all the best. And at this juncture, I want to hand over to the president. Thank you very much, ma. And everybody.
Yes, thank you, everyone. This has been one of the shortest webinars we have had for obvious reasons. The presenter has done pretty much well. I'm sincerely very happy with the delivery, and I want to thank her and also thank her trainers, because there's obviously a part of a good trainer who has been involved in this output. So on that note, I want to also thank the moderator. You have all done well. Please don't begin to disappear from the platform, my people, because you also have to hear the business information, administrative information. Please, we won't take long. So this trainee segment that we have brought before you all, it has been targeted to ensure that we train our trainees in the art of delivering webinars. And we've been so proud of how they have performed as presenters and as moderators. I'm not too sure many of them have done it on a national level, but we have provided this challenge for them to come out, and therefore you should be bold, you should be proud to go even further to the international scene. It's just about, knowing about the rules of public speaking, and you have done that very well. So thank you, Dr. Shuaib. Thank you to all the trainees. Thank you for your attendance always, and also to all the trainers. I want to also thank my president-elect. He has done so well, coordinating this. We are coming to the end of our tenure as ESCO, and we're just 5 weeks away to handing over. And I'm so happy and comfortable and proud that I'll be handing over to Dr. Deti, although Dr. Banner has promoted all of us. He has called all of us professors. So we'll receive it, inshallah, by the grace of God.
Amen.
So it's well. So I'll be handing over to him very soon. Please, we will continue this segment, like Dr. Shaibu said, after the national exams. And let me not actually deny the truth. After the national exams, there's going to be an international conference, Pan-Africa Anesthesia Conference, and there's also going to be the Anesthesia National Conference, our NSA conference. And we'll just have 2 weeks in December before the Christmas break. I'm not very, very sure we'll be able to have any outing. So I feel strongly that our next webinar series, which will be the 8th series of webinars, 8th session rather, will be next year. So we want to sincerely thank you all for supporting us in these educational webinars. We want to thank you for your funding, which you have also used, because we subscribe to Zoom platform and we take money from what you have put in as your dues. We want to plead with you to please continue paying your dues faithfully. And to those who are eligible for life membership, please look into the opportunity of paying as a life member, so that the way economy is going in Nigeria, even though we pray this tide will be stemmed, you would have an advantage, because we may have to increase our dues very soon in the coming year. So, but we pray things will get better in our dear nation. I would like to say that elections are near. Please get interested in NSA elections to serve this society better, and you would not have a regret. You would learn more, right? You would learn more by being a leader. So on that note, I want to thank every one of you. I wish you a successful outing in your exams. From this coming week, both examiner and student will begin to travel. I wish you all a safe journey. And I pray that we will continue to be blessed. I want to also greet all teachers. Today is World Teachers Day. It's not easy to be a teacher. It's a calling, it's a passion. So congratulations to all teachers on the platform. Even as residents, you are teachers, because you teach medical students, you teach yourselves. So happy Teachers Day to all of you. Thank you, and thank you once again to everyone for keeping this time out with us. On that note, I would like to say goodbye. Please, before I say goodbye, don't forget World Anesthesia Day. We have thrown out a notice. This year happens to be World Restart a Heart Day. I've seen it all on the platform. I won't waste your time by saying too much again. We have to make ourselves relevant. And you can see on our platform, our Mama, Professor Sheyo, has validated our plan. So please, let us all as anesthetists teach people in our environment, BLS. Please, let us take the bull by the horn and make that sacrifice to pass on CPR, BLS to those around us. Please post your pictures. But on October 16, there will be a webinar by WFSA on workforce well-being. Please log in and don't be left behind, so that you can know everything about workforce. Well, I may not be talking to you again until during the elections NSA conference. So thank you. You have been very supportive to me. I'm happy. I felt so comfortable and loved by you all. And you have made my tenure a successful one. Thank you to every one of you. Thank you to my ESCO members. Thank you to the Board of Trustees. And I'm deeply indebted to you all, and I love you all. So good night.
Thank you, ma'am. We have started missing you.
Thank you, ma'am.